He subsequently served in the Navy, first at the Balboa Medical Center, serving the Marine Corps, and also performing a transitional year there. He subsequently went to Pensacola, where he worked and served as a flight surgeon. And then after being honorably discharged from the Navy, he came here to the University of Wisconsin-Madison to pursue his anesthesiology residency. Following this, he trained at Virginia Commonwealth University in Virginia, doing a sorry, I just got a call right when that was happening. Sorry about that. So after he finished his pain fellowship, he returned here to UW to practice in the interventional pain area. So we're looking forward to hearing this talk today, Dr. Pride.
Okay, just to confirm, you guys can hear me and you can see my first slide?
That's correct, we can.
Excellent. Good morning, everyone. Thanks for that great introduction. And as Dr. Lake mentioned, I'm going to be discussing peripheral nerve stimulation today. Altered my title slide here a little bit. I wanted to retitle it "A Shocking Alternative for Pain Management." But we're going to talk a little bit about basically peripheral nerve stimulation, where it's been, where it's going, and where it currently is right now. So my disclosures, I currently have none. And my objectives today, they're as follows. I want to analyze the pain pathway, including the contributions of both peripheral and central sensitization. And I'd like to evaluate the current understanding of the gate theory of pain, specifically as it kind of relates to neuromodulation. I want to be able to better assess maladaptive cortical plasticity, as well as its role in chronic pain patients, and dissect the history of peripheral nerve stimulation by identifying some indications, contraindications, challenges associated with its use, and things like that. And then lastly, I want to try to explain the theoretical framework behind peripherally induced reconditioning of the CNS. So let's start off with kind of a brief review of the pain pathway. I think, as we know, it begins with a noxious stimulus to the periphery. So this is then sent to the spinal cord, by small diameter first order afferents. So these are typically separated into those first pain A delta fibers, as well as the second pain unmyelated C fibers. And from here, it reaches the dorsal horn. It synapses on the nociceptive specific or wide dynamic range second order neurons. And then these project to the brainstem of the thalamus. And then at the level of the brain, these signals are processed in a set of kind of different regions, which is oftentimes referred to as the pain matrix. Yes, that matrix. And this particular matrix kind of includes the thalamus, as well as the somatosensory and insular and prefrontal cortices, and also the amygdala and the hippocampus. So next I want to take a quick look at peripheral sensitization. So again, here we see peripheral stimulus. In this case, it involves some longer lasting form of nerve damage or irritation, which then results into this huge release of pro-inflammatory cytokines and neuropeptides at the site of the nerve. This will cause an eventual reduction of the nociceptive threshold, making it easier for these signals to be sent. Another way to say this would be a relatively lower or an equal stimulus intensity results in a higher, or equal stimulus intensity results in a higher pain intensity. The next step we see this hyperexcitation of the nociceptive afferent nerve, which now is resulting in spontaneous discharge as well as hyperalgesia. So it's a quick, kind of a dirty review, but nonetheless, hopefully effective for our purposes. I'm just going to jump into central sensitization. So this is probably a little less well understood, but it can and often does happen concurrently with peripheral sensitization. This will be a busier slide, but please bear with me now. Again, we see an initiating event of nerve damage. This results in kind of an influx of ions, except this time we observe this at the dorsal horn. An influx of calcium ions here, as well as phosphorylation of multiple ion channel receptors. And there also occurs a sensitization this time of both nociceptive specific and wide dynamic range neurons, which contributes to the next step, which is a decrease in GABA and glycinergic inhibitory drives. This absence of normal inhibition leads to further amplification of excitatory PKCY gamma interneurons, and this enables sometimes what we consider or possibly could consider allodynia. And now we move from the dorsal horn, sorry about that, to the supraspinal circuits and somatosensory cortex. In the somatosensory cortex lies this nociceptive representational zones, which are just what they seem. They're basically pain areas. During central sensitization, these areas, they begin to exhibit a sensitized state, and this can often be characterized by an expansion or a shifting of pain representations. In contrast, the non-nociceptive zones or non-pain areas may diminish in both their size and in their response to activation. So now what we've described is something called activity-dependent cortical remapping. In essence, the pain signals have increased, so they need a bigger and possibly a different or larger landing area. And the non-pain signals, they relatively decreased, creating a smaller representational zone. So another phrase to describe this would be maladaptive cortical plasticity. And the effect is you have more nociceptive signaling, abnormal tactile sensations, pain hypersensitivity, as well as allodynia. This brings us to the gate theory of pain. Another word for this is spinal segmental mechanism of analgesia. Not that that's that important, but it is this theory that attempts to explain more why neuromodulation helps provide pain relief. According to the gate theory, A-alpha beta fibers generally transmit signals from low threshold mechanoreceptors and proprioceptors. Their successful activation then often elicits these non-painful sensations in the innervated area. Experimental studies, they've exhibited the profound control that these A-alpha beta fibers exert over the transmission of nociceptive signals in the spinal dorsal horn. And this occurs both presynaptically as well as postsynaptically. So what does this picture of Charlie Day represent? Well, good question. First, it depicts probably how some of you might be feeling already, a little overwhelmed by this large amount of carefully researched and expertly presented information. Secondly, maybe he has a headache. So the rubbing of his temples is an example of him utilizing the gate theory of pain. By applying pressure and touch to his temples, he's stimulating these A-alpha beta fibers to overcome and hopefully interrupt any pain signals that may be arising from this area of his head. There are, of course, some additional hypotheses to supplement the gate theory of pain. Peripherally, perhaps the nerve fibers have developed an altered level of intrinsic excitability. Essentially, perhaps the level of neurotransmitters has been induced or depleted, or the actual expression of the signaling proteins is being modulated. But these hypotheses notwithstanding, the gate theory remains the predominant theory for pain relief with conventional neuromodulation. So let's compare different pain pictures at the level of the neuron. First, what is happening when there's no pain? Well, there's a balance between nociceptive and non-nociceptive signaling. And so the results, you get minimal activation of a nociceptive projectional neuron. In the diagram here, we depict four sections, the first being labeled number 1 here, which represents the postsynaptic and active inhibition of the nociceptive neuron. Number 2 represents the presynaptic and active inhibition of the nociceptive neuron. And number 3 represents the inhibited PKC gamma excitatory interneuron. Number 4, and that's the non-firing but polysynaptically excitable nociceptive neuron or pain nerve. So what is this demonstrating? It's showing that the nociceptive neurons can be altered, affected, and modulated at a variety of different locales along the signaling pathway. So next we have an example of unmodulated pain. So the firing of this pain nerve is characterized by increased excitability, decreased inhibition, and illustrated here we see the same set of neurons, and this depicts a decreased pre- and post-synaptic inhibition of the nociceptive neuron. Number 3 shows a lack of this inhibition of the excitatory neuron, possibly again resulting in allodynia. And lastly, the now excited polysynaptic nociceptive neuron. Finally, we show modulated pain through the use of spinal cord or peripheral nerve stimulation. As you can see, the inferior-most A-alpha beta segment is now firing, causing an elevation in both the pre- and postsynaptic inhibition of the nociceptive neuron. There's also a return of inhibition of the PKC gamma excitatory neuron, and consequently an overall reduction in the firing of this pain nerve. So let's move back to maladaptive cortical plasticity. This is a term that I believe itself is undergoing some change, or plasticity, if you will. I think initially it referred mostly to the change in one's cortical remapping after amputation, as in describing phantom pain. But now I think its definition is broadened to also include cortical changes we sometimes see from chronic pain. So to define it, it's the process by which an existing cortical map is affected by a stimulus or lack thereof, resulting in a creation of a new and likely more dysfunctional cortical map. So let's review some of the evidence behind maladaptive cortical plasticity. This is a dated study, so this is back in 1997. Flora et al. Performed a study of 19 patients, 10 with chronic lower back pain and 9 controls without. And they applied intracutaneous stimuli to both the low back and the finger at a painful and non-painful intensity. Magnetic fields were recorded by a biomagnetometer from the hemisphere contralateral to the site of stimulation. What their study showed was that substantial and significant increases in cortical activity were only present in patients with a longer duration of pain, or with longer pain duration. In the brain diagram here, the cortical representation of the lumbar region, or the circle, had shifted toward a more medial position in the cortex in the chronic pain, back pain group. And their data suggested not only enhanced reactivity, but might indicate an expansion of the lumbar representation into neighboring foot and leg areas in chronic pain patients. And so the takeaway, the nociceptive zone in the somatosensory cortex likely expands, or at the very least shifts, in patients with chronic pain. In this next study, Pleasure et al. Compared healthy patients to those with upper extremity CRPS by using two-point discrimination to measure the effects of graded motor therapy in this study. What they revealed was essentially twofold. First, that through the use of graded motor therapy, two-point discrimination and the non-nociceptive zone can be improved and enlarged back to its previous size in patients with CRPS. And second, that by using contrast brain mapping, they showed that a decreased cortical response to innocuous stimulation and a smaller representation to the finger and the cortex during innocuous stimulation. So to simplify, in these CRPS patients, the data suggests that there is a shrunken non-nociceptive zone with a decreased response to innocuous activation. So to summarize, one, there's an expanded or shifted nociceptive zone in the somatosensory cortex in maladaptive cortical plasticity. Two, there's a shrunken non-nociceptive zone with a decreased response to activation. And three, these are both likely secondary to some unbalanced sensory input caused by chronic pain. So can we fix it? Can the balance be shifted back? Is there such a thing as readaptive cortical plasticity? Well, conventional or kind of older peripheral nerve stimulation does not reverse this process. And I may refer to peripheral nerve stimulation as PNS going forward, and spinal cord stimulation as SCS. So, but neither SCS nor dorsal root ganglion stimulation has been shown to reset this process. And as we discussed, graded sensory motor retuning with desensitization therapy can improve this in CRPS patients, or graded motor therapy. But this is not necessarily neuromodulation in the context that we think of, so we move forward. Based on what we know, in order to achieve this, it should seem pretty straightforward. We have to increase the nociceptive input, increase the non-nociceptive input, decrease the nociceptive input, and balance this, which is currently unbalanced. Which brings us to neuromodulation. Admittedly, this practice has been around for quite some time. Wikipedia would have us believe that it dated back to the time of Christ or sometime thereabouts, when a physician or practitioner, Scribonius Largus, the court physician for the Roman Emperor Claudius, used electric eels to treat arthritis, gout, headaches. He described these methods in a collection of treatments he entitled the Compositiones Medicae. This is probably a pretty good beach read, but you'd need to scrub up on your Latin. Interesting nonetheless, though. Now, I won't discuss every one of these milestones here because I'll touch on some later, but these are the high points of the history of peripheral nerve stimulation. In 1967, Wall and Sweet placed an infraorbital electrode to demonstrate proof of principle. 1 year later, Sweep and Wepsick would implant the first reported peripheral nerve stimulator in an effort to treat CRPS. Several milestones later, in 2009, Dr. Mark Huntoon, prior to becoming my attending physician at Virginia Commonwealth University, and his partner Berger first demonstrated ultrasound-guided percutaneous placement of a peripheral nerve stimulator. 6 years following that, the FDA cleared the first percutaneously implantable peripheral nerve stimulator. Then, in 2017, clearance was granted for the first 60-day percutaneous temporary PNS system. Now, why would they do that? Why only 60 days? Well, it's because evidence was coming out that in some forms of chronic pain, could not only be managed by PNS, but also treated in a more permanent way through the application of temporary peripheral nerve stimulation. Then, just 2 years ago, Gilmore et al. Published a randomized controlled trial demonstrating sustained relief of post-amputation pain at 12 months following a 60-day temporary percutaneous placement, which I'll discuss a little more in detail here. So, compared to other technologies, the evolution of peripheral nerve stimulation has been relatively slow. Well, why is this? Well, due to its invasive nature, prior to the more ubiquitous use of ultrasound, it was considered more of a treatment of last resort. And this is because nerve stimulation placement often required surgical intervention, as you all know. There was a lack of stimulator systems designed for the periphery, and so physicians were having to use leads designed for the epidural space. There's still the significant mechanical stress that takes a toll on leads that are implanted in the periphery. And there were also more frequent lead fractures when compared to spinal cord stimulation. And lastly, and certainly not the least, there's always the challenge of targeting distal nerves that require having to tunnel leads across a joint or an area of significant motion. Nevertheless, PNS has indeed evolved. The concurrent evolution of the ultrasound has greatly enhanced nerve visualization, and consequently, it's allowed a larger group of nerves to be targeted for stimulation. There's also been an increase in the number and the quality of interventionally trained pain physicians. Reimbursement of PNS has grown, and external forces and governmental pressures for newer non-opioid treatments for both acute and chronic pain has surely enhanced the research in this area. As I'll discuss, longer-term efficacy of percutaneously implanted leads without an internal pulse generator has also increased, coinciding with the improvement of some lead material and design. And the newer leads incorporate sometimes open coils with an increase in axial flexibility. This design is thought to enable tissue growth within the coils, better securing the leads in place, which can help reduce pistoning and consequently reduce the rate of infection. So it's known that we have, and we discussed, that conventional PNS can prevent pain via this gate theory, but not produce a sustained pain relief. So why is this? Well, what we know is that conventional leads have a relatively small surface area, and conventional stimulation oftentimes use wider pulse durations. And together, these produce a more intense electric field, as kind of shown here, or what's upcoming. And this electric field decays rapidly across short distances. So for this reason, they have had to be placed quite close to the target nerve. The result is that fibers near the electrode may be activated, including the small diameter pain fibers, while fibers slightly more distal to the electrode, like those deeper in or across the nerve, may experience little to no stimulation. And so this can lead to painful sensations at a relatively low level of stimulation. So the result, you have a small therapeutic window where small movements in lead position or a change in stimulation can result in a change in pain relief, a loss in pain relief, or an increase in pain sensations. We see this graphically represented by a small cross-hatched area of the bar graph between the thresholds of the first sensation and then the first painful sensation. So insert 5-0 reference, is there something better somewhere out there? I sing this song with my daughter every night. We open the window, the whole neighborhood hears us. Nobody's probably listening, but it's a great movie and one of my favorite songs. Onward, so let's talk about a little bit of studies. we're going to compare, give me 1 second here. In 2004, Shou et al. Performed a multi-center, single-blinded randomized controlled trial of 61 adults, and they had chronic shoulder pain and subluxation after stroke. They employed a 6-week treatment using 4 intramuscular leads, and they stimulated the supraspinatus, posterior deltoid, mid-deltoid, and upper trapezius muscle for 6 hours a day. Although this was not an actual peripheral nerve stimulation, as I think we currently understand it, it did accomplish a comparable action with this intramuscular stimulation. The control subjects were treated with just a cuff-type sling for 6 weeks, and their outcomes were measured using a BPI, or brief pain inventory, administered in a blinded manner at baseline and at the end of treatments, as well as 3, 6, and 12 months post-treatment. Treatment successes were noted as a minimum of 2-point reduction in BPI at all post-pain assessments, as well as a host of secondary measures there. What this study showed was that at 1-year follow-up, the electrical stimulation group had a significantly higher success rate than that of the controls, 63% versus 21%. And that's what this this is what this graph depicts here. So another study 9 years later, performed by Wilson et al., is a single-site pilot RCT in 25 adults, again with chronic post-stroke shoulder pain. A 3-week treatment was employed using a single lead peripheral nerve stim or usual care, including physical therapy. The PNS lead was placed at what they described as the targeting the terminal branches of the axillary nerve, which caused contraction of, this time, only the middle and posterior deltoid muscles. So this time, no supraspinatus or trapezius. The primary outcome was the worst pain in the last week as measured at baseline and at weeks 1, 4, 12, and 16, with secondary outcomes being pain interference and health-related quality of life. In this study, they concluded that short-term PNS is safe and efficacious treatment for shoulder pain, that pain reduction was greater in the short term in PNS than when compared to usual care, and is maintained for at least 12 weeks after treatment, and also provided an improved quality of life as they measured by the questionnaire, the SF36 V2 health survey form. And further, they postulated that stimulation of these terminal branches of the axillary nerve with a lower frequency, for example, 12 hertz pulse train, likely has a dual effect. First, activation of sensory afferents, sensory afferents, and second, activation of muscle efferent fibers, producing proprioceptive afferent signals in large diameter fibers. To quote them, they said, together the non-noxious proprioceptive and cutaneous afferent barrage may engage the gate mechanism in the spinal cord and also facilitate cortical neuroplasticity and representational remapping, potentially reversing the cortical contribution to the chronic pain state. Okay. So where else does this sort of stimulation have good efficacy? Well, in 2018, Gilmore et al. Published a multi-center RCT with 28 lower extremity amputees with moderate to severe post-amputation pain with no constraints on time since amputation. They received an 8-week treatment, this time using 2 percutaneous PNS leads targeting the femoral and sciatic nerves. So this time it was an 8-week treatment, not 3 weeks. One of their primary benchmark measurements was which patients achieved a greater than 50% pain improvement in pain score. In their results, a significantly greater proportion of subjects receiving PNS had reductions in had greater than 50% reductions in average post-amputation pain scores during weeks 1 to 4. Significant greater proportions of PNS subjects also reported this similar pain improvement in weeks. And pain interference after 8 weeks of therapy. 4 out of 5 PNS subjects who completed the 12-month follow-up also reported greater than 50% pain relief. The figure here depicts a proportion of patients in the treatment group who completed an 8-week treatment distinguished by their severity of pain, green, yellow, or red, at baseline, end of treatment, and then 12 months. Notably, more than 50% of patients reported pain scores ranging from 0 to 3 at the end of treatment. So I think the glaring question that arises here is why the prolonged relief? Why this type of stimulation? Why from this type of stimulation and why in these patients? Well, one hypothesis is that longer-term pain relief is achieved by targeting mixed motor and sensory nerves using lower frequency that activates both sensory afferents and muscle efferents. So both the shoulder studies we examined that provided long-term pain relief described stimulation of the shoulder muscles. As shown in the RCT by Wilson in 2014, efferent fiber activation in the terminal branches of the axillary nerve caused non-painful contraction of those deltoid muscles, which produced proprioceptive signaling in large diameter fibers that engaged the gait mechanism and perhaps played this larger role in reconditioning the cortical plasticity. Another hypothesis is one describing which nerves are being postulated, or which nerves are being stimulated, or more accurately, which part of the nerves. So from previous research and the aforementioned studies, we recognize that activity-dependent cortical remapping requires that the peripheral conditioning input to the cortex be two things. First, that it be robust and it affects multiple sensory nerves. It has been shown that sufficient signal strength is needed to drive this plasticity change. And secondly, that the stimulation be focal or from a specific painful region. This is because functional plasticity relies on a low relative activity in the surrounding cortical regions. Okay, so where does the current landscape of neuromodulation fit in this robust versus focal grading scale? Well, below we see a red area on the brain signifying the location of the cortical pain signal, and green dots illustrating the area of a alpha beta sensory stimulation provided by each of these devices. So let's start with spinal cord stimulation. This represents neither robust nor focal stimulation, as it affects spread across multiple dermatomes due to a lack of somatotopically targeted stimulation. It also activates only a small proportion of A alpha beta fibers, as we noted earlier, before really becoming uncomfortable. Next is paresthesia-based dorsal root ganglion stimulation, which is notably more focal than SCS. Unfortunately, it is still not very robust, as these leads lie very close to the nerves within the intraforaminal space, and again, they have lower thresholds prior to pain stimulation. So picture C here, picture C depicts a conventional PNS or permanent PNS, which is even more focal than DRG and is what we would consider focal, but not robust. We encounter the same problem. These pain fibers are activated prior to reaching a robust or a more robust level of stimulation of the surrounding adjacent sensory nerves. And in the picture in D, it represents the goal or the objective, a peripheral nerve stimulator that can achieve both of these. So how do we achieve this robust stimulation without breaking the discomfort threshold? Well, more specifically, what has changed in the realm of peripheral nerve stimulation that enables us to achieve this? Well, there are different lead types. Some of the newer leads use a smaller diameter, open helical coil that I mentioned earlier. A lead of this design can be up to 5 times longer and greater than 1.5 the surface area of a conventional lead. When combined with monopolar stimulation, it can create a signal that reaches nerves up to 3 centimeters away. And helical shape, like I said, also can reduce the risk of infection due to its fibrotic ingrowth and decreased pistoning. And lastly, there's a terminal anchor at the electrode which can help resist migration, which is not usually present on conventional leads. So to quickly review, the coiled lead and the coil design and the terminal anchor provide a migration-resistant lead, while a monopolar electrode, narrow pulsation, and a larger surface area provide a broad and relatively homogeneous electric field at remote distances. So together, these features, they've enabled a more remote lead placement, allowing a higher tolerable stimulation level, which leads to more robust stimulation and a greater opportunity for reconditioning maladaptive cortical plasticity. So to depict this graphically, we see a large therapeutic window of comfortable stimulation where small movements of the lead shouldn't greatly change stimulation pattern or the level of discomfort. We haven't really discussed stimulation type, which I will do here briefly. The challenge historically with peripheral nerve stimulation has been to selectively activate the pain relieving or large diameter pain fibers or large diameter myelinated fibers while avoiding the activation of smaller diameter type 3 and 4 pain fibers. This selective activation of large over small diameter fibers improves not only as the distance between the electrode increases, but also as pulse duration decreases. Thus, we see a relative shifting of the paradigm in this peripheral nerve stimulation model. Conventional PNS used wide pulse durations multi-electrode leads placed quite close to the target nerve. Newer PNS uses more narrow pulse durations, plus or minus a lower frequency of targeting a mixed nerve, with a single monopolar electrode placed a little bit more remotely from the target nerve. So what are the drawbacks of conventional neuromodulation? As most of you probably know, and if you're in my business, you know that it presents quite a dilemma when it stops working. What do you do for the patient? Take it out, leave it, contact the device representation to try and revive it. It can also prevent advanced imaging such as MRI in a patient with a known anatomical injury. And the picture here is actually one showing leads stimulating a couple of dorsal root ganglia. So as you can guess, these can be pretty challenging to place. So what are the benefits of a temporary or percutaneous PNS? Well, like conventional neuromodulation, it creates an opioid-sparing post-op indication, as well as it's non-invasive. It's easy to place. It can be easy to remove as well. It also has a relatively lower infection risk, as I mentioned before, a reduced incidence of fracture and migration, and has a lower side effect profile. It can be placed in a patient who is otherwise a poor surgical candidate on chronic anticoagulation and perhaps not tolerant to other pain meds. And then lastly, oftentimes and in some situations, it can provide long-term pain relief post-removal. And so here I feel like I would be remiss if I didn't at least touch on where this intervention belongs in the nerve treatment algorithm, or I should say nerve pain treatment algorithm of neuropathic pain or other chronic pain. And herein lies the rub. As shown in this timeline, I lifted from one of the PNS companies. Not surprisingly, they would have this intervention be placed pretty early on, prior to nerve ablation or radiofrequency ablation. I think that more realistically, it's probably applied farther down, at least right now, and perhaps maybe not at all. But there's some food for thought. Gaps in knowledge, these are but a few. First, what are some of the better indications for the usage of peripheral nerve stimulation, permanent or temporary? What is the effect and the utility of efferent fiber activation on reconditioning? Is there any utility to performing a diagnostic block these days? Should we be employing this therapy earlier on in the treatment algorithm, as I just mentioned? And then regarding duration, what's the optimal duration of therapy? What is the duration and also the likelihood of relief? And does this differ among nerve targets? And when does a patient become a candidate for permanently implanted leads? Lastly, what are some adverse outcomes in the long term? What can we expect? That concludes my presentation. There's a quick pic of my 3 kids on laundry day. Usually those baskets are full of clothes and we see less smiles. So, and there are my references. So I'll open the floor to questions at this time, but I thank you for your attention so far.
Thank you, Keith.
Yeah.
So we have questions from especially our spine and pain doctors, Wendell and such.
I have a quick one. Do you use trials at all, or you just do the permanent implant?
So it kind of depends. It depends on what I want to try and go for. So one of the companies is called Sprint, and that's pretty much the company that I was describing a lot of today. So they employ this 60-day therapy, and they have this longer term pain relief sometimes thereafter, depending on what the nerve target is. And that's at multiple locales. One of my favorites is the suprascapular nerve for shoulder pain, whether it's from osteoarthritis or other. And so what my kind of algorithm is in a lot of target peripheral nerves is place this 60-day percutaneous implant, oftentimes with 2 leads going to one adhesive generator right on the skin, and then see how that does. And then reevaluate 1 to 2 months thereafter, after removal. So 3 months, 3 to 4 months after implant. If it works and continues to work, fantastic. If pain comes back, I'm at a crossroads of employing or implanting another percutaneous temporary one, or depending on how long it worked, then I would consider a permanent placement. There are patients in situations where insurance companies don't cover this temporary 60-day. And so at that point, I would just start off with a 7-day trial, the conventional trial that you're probably used to. So, the landscape is changing. I definitely don't represent all pain docs and what they do, just because I think some of this technology is, changing every week and every month. So everybody kind of does it a little differently, but that's primarily how I proceed with these types of patients.
And in your opinion, what's the place of surgical lead placement? Or when would you refer somebody for surgical lead placement?
That's a great question. I think if the patient were a little bit beyond, like if targeting the nerve was too deep, or perhaps I thought too difficult for me, sometimes maybe sciatic if it were gluteal. Honestly, I don't refer too often for surgical placements of peripheral leads, just because I've had success with placing either the Sprint temporary lead, or I have had success just placing a StimWave permanent lead where I don't need to place a generator. I'll just place the lead, and then there's a wireless remote. So.
Okay.
Any other questions?
No, go ahead.
I was just going to ask, one of the problems with StimWave initially was trying to keep the inductive stimulator positioned appropriately. Has there been any recent changes in that technology, the inductive stimulator?
I think another problem with StimWave, and this is an anecdotal personal thing, is that we don't have a lot of great representation in Madison. I think they have a Chicago coverage, and we're kind of an afterthought, whether it's because we don't do enough or some other reason. And so that would be my biggest beef with StimWave. But as far as coverage, I haven't had much problems with that. So whether their technology is advanced and I've been not aware of it, that's one possibility. I will say that we just recently got approved a device called NALU, where it's a very small IPG. It's like the size of a dime, and that gets implanted with the surgical lead. And there's an external device, or an external IPG with an internal battery, and it's a lot easier to place. It doesn't require a lot of surgical intervention, but it's more than just implanting the lead. And some of the signaling and picking up that signaling might be improved when compared to StimWave, but only time will tell, I think.
Thank you very much, Keith. I really, as I said at the introduction, everything old is new again. So this is important for them to know. Thanks very much. Appreciate it.
No problem. Thank you so much. I don't know how often you guys encounter that post-stroke type of shoulder pain, but as I alluded to in those kind of exams and studies, that there's a great spot for this for those particular types of patients. I think when we see that there's not a lot of anatomical change or anatomical pathology where we're just trying to fix some sort of neurological deficit, that this has a very good place and a very effective role. So keep us in mind for that. But again, thank you so much for your attention and the invitation. It was a pleasure, and have a good day.
Thank you very much.
No
Bye.
problem.